Welcome to this week's edition of Ask an MS Expert. I'm John Strum, and I'm the host of the Real Talk MS podcast. Each week, Real Talk MS reaches thousands of people in more than 90 countries around the world with the news that people affected by MS need to know. I'm also a member of the International Progressive MS Alliance Scientific Steering Committee. I'm a district activist leader and trustee for the National MS Society, and I chair the Society's California Government Relations Advisory Committee. My wife, Jean, lived with progressive MS for 23 years, so I've had a front row seat experiencing all the ways that MS can impact family. I'm thrilled to be with you today, and I see that people are continuing to join our webcast, so let's give them just another few seconds and then we'll get started. Thank you to all of you who are joining us on GoToWebinar, Facebook Live, and YouTube Live. The MS Society's Ask an MS Expert webcast is designed to connect you with MS experts who are ready to answer your questions about the topics that impact people affected by MS every day. So as I chat with our expert today, thank you to all of you who are joining us questions on GoToWebinar, Facebook Live, and type them into the question box. The MS Society's Ask an MS Expert will try to answer as many of your questions as we can during the Q&A portion of today's program. Magnetic resonance imaging, better known as MRI, is the diagnostic tool that offers the most sensitive, non-invasive magnetic resonance imaging the brain, better known as spinal cord, and other areas. Is the diagnostic tool that offers the preferred imaging method, non-invasive diagnosis of MS and to monitor the course of the disease. To learn more about how MRI helps magnetic resonance and management of MS, MRI, we're talking with Dr. the diagnostic Sicotte, tool that offers the most sensitive professor and chair of the Department of Neurology at Cedars-Sinai Medical Center in Los Angeles, California. She's also the director of the Multiple Sclerosis and Neuroimmunology program at Cedars-Sinai. And Dr. Sicotte's research focuses on the use of advanced structural and functional imaging to study MS disease progression. I'm delighted to have her with us today. Welcome, Dr. Sicotte.
Thank you, John. It's my pleasure, and I'm looking forward to today's webinar.
Well, maybe a good place for us to start is with a simple question. What is magnetic resonance imaging, and how does it work?
Well, that's a great question, and it's a wonderful tool that is so flexible and allows us to image the living body in many ways. Thank you, John. It's my pleasure. It has a lot of advantages in that it doesn't involve ionizing radiation, so we can do multiple studies without any harm to the body or exposure to radiation, so that makes it a really useful tool. Really, what we're doing with MRI is taking pictures of water molecules. And it turns out that our body is mainly made out of water. And an MRI scanner uses powerful magnetic fields and then introduces electromagnetic energy to make those water molecules spin in a certain way. And then we can collect that information as those spins relax, and it gives us a picture of the living brain or living tissue anywhere in the body. We can also use MRI to look at flowing blood. And we can even use it to get pictures of brain activity by using small changes in the oxygen level of that flowing blood to do brain activation studies. We can also use it to look at small amounts of other chemicals besides water using something called spectroscopy. And because of the advances that have gone on, we're now able to track specific pathways in the brain, look at those pathways in relation to those areas of activity. So it's a very versatile and powerful tool that allows us to study not only MS, but other neurologic diseases as well.
And what is it about MRI that makes it such an important tool for diagnosing MS?
So one of the wonderful things about having this tool available to us is it helps us in many ways throughout the course of MS. So it helps us in the beginning to diagnose MS. So as you know, from your experience, and I'm sure from patients who are here on the call, symptoms associated with MS can be confusing. They can be confused with other kinds of conditions. And so having this ability to examine the brain tissue to see if there are changes within those regions that are consistent with what we expect to see when someone has a diagnosis of MS can be very helpful. In addition, through research and all of these years that people have been using MRI to study MS, we've learned a lot about the disease itself. And one of the most important things I think we've learned is even though a patient may be feeling fine, not having symptoms, not having new problems, when we do MRI scans periodically, we see that there is a clinically silent inflammation that can go on. So a patient feels fine, but the disease is still active. And this was a big insight that was gained by using MRI to monitor disease activity. And so this really led us to the conclusion that we need to be using MRI as well as our clinical evaluations to know for sure if the disease is really active. And then secondly, or thirdly, I should say, we use the MRI to monitor treatment effects. And so when we were doing clinical trials, this was very powerful in allowing us to see the effect of new innovative medications in suppressing that clinically silent activity within the brain, as well as decreasing those clinical relapses. And then finally, we're now using newer techniques, even more advanced imaging, to try and understand from the very beginning of the disease if a patient has markers that might suggest more significant risk for, as you have mentioned, progressive MS. So can we use MRI at the very beginning of diagnosis to stratify individuals into those who we really need to focus our therapies on, or maybe other people whose disease might not be so significantly or severe, so that we don't necessarily have to use the most powerful medications. And we're just starting to do this work, and I think it's going to be really impactful given how many therapeutic options we have now, which is a real bonus, but really knowing how we can use the MRI to pick the right therapy, do what we would call personalized medicine for our patients.
Well, every bit as important as getting that MRI exam is having the image read or interpreted. What are some of the common challenges healthcare professionals are faced with in interpreting MRI?
So this is a great question, and part of it has to do with the accessibility of seeing the scans yourself. And we spend a lot of time with our patients in our clinic actually collecting those scans, either on CDs or trying to do it electronically, so that we can actually look at the scans ourselves. So most MS experts will do this because the way that an MRI is interpreted depends a little bit on the eye of the beholder, if you will. And we know that neuroradiologists or radiologists who read MRIs may have varying degrees of sophistication when it comes to the diagnosis of MS. And what we've also learned is that those scans can be difficult to differentiate between MS versus some other condition. And work that we've done in our clinic and throughout other locations, including at the University of Vermont, has shown that there is a high degree of misdiagnosis of MS, in part based on these interpretations of MRI scans. So it's really challenging, I think, for a neurologist in private practice who doesn't have the time or the infrastructure to look at every single MRI scan that comes through for patients. And sometimes the MRIs are misinterpreted and they can lead down the wrong pathway and end up with people being diagnosed with MS who actually don't have MS.
Are there different types of MRI scans that are used in diagnosing or following MS once it's diagnosed?
Yes, so you may know, and our patients may know, that the first time you get an MRI scan, very often you will receive the contrast agent, which is a gadolinium-based contrast agent. And that's to allow us to really make a diagnosis and to see if the disease is active. So what we do know is that if you're having a new area of inflammation, the gadolinium will leak out and you'll see a bright spot after the contrast, what we call the post-contrast scan. And so that really gives us a time stamp, if you will, of that disease activity. In addition, we look at the non-contrast study that shows us all the areas, what we call the T2 or the flare, that shows us all the areas where there may have been inflammation both current and in the past. So we have both of those pieces of information. What we are learning over time is that we may not need to use gadolinium every single time we do an MRI. And that there has been some data about gadolinium and some concerns about it. These are, the truth is, very minor concerns in terms of our thinking about gadolinium risk. We think it's very low, and the newer agents are not associated with some of the changes that people had seen with the old agents. But we are cognizant of the fact that people are less, have questions about that. And the truth is, it's expensive to use gadolinium. So we are changing a little bit the way our protocols are. So for subsequent scans, as long as we have a good baseline to compare, we're not always using the contrast scan in the follow-up. So, so we would expect that patients should assume they'll have an MRI at the very beginning. And we like to do the entire brain and spinal cord. So we do the cervical cord and the thoracic cord to really get a sense of where there might be disease activity. And then we tailor the scans subsequently based on clinical activity and also where there were lesions before.
Talking about those subsequent scans, how often should people with MS expect to have an MRI?
So I think it really varies, and there are different ways that people practice. In our practice, and I think for the vast majority of MS specialists, at least once a year, you should expect that you would have an MRI scan. Now, whether it will be the entire neuroaxis depends on your own particular kind of disease and disease activity. So we normally will do at least the brain once a year. You may have it more frequently if you're having a lot of new activity. So if you're having new clinical symptoms, that might prompt an early return to the MRI scanner to really evaluate those symptoms and see, is this a relapse or is this an old symptom that's come out again? Has there been a lot of change because there's a lot of symptoms that are going on? And then another time where you might have it more frequently is if you're changing medications. So we really like to have what we call a clean baseline when we start a new medication. And so we want to be able to know what was the disease activity like at the very beginning when this medication was started so that we can compare it, say, a year later or several months later and see if there's been any change. And sometimes when you start a new medicine, depending on the medication in particular, you may have an early new baseline scan after you've been on the medicine for 6 months and the medication is on board and it's working. Then we sort of start with a new baseline at that 6-month time point. So a lot of it does depend on how active your disease is, what medications you're on, and how stable your medication regimen is.
We've heard from Sarah, and she's asking whether the strength of the magnet used in an MRI machine is important. So do magnets with different strength provide different information?
So it's a great question. So the typical strength of a magnet, at least previously, was 1.5 Tesla. So they're measured in units of Tesla, which is a magnetic field strength. And so then now we have mainly now in clinical practice a lot of 3 Tesla scanners. That's kind of a typical scanner that's available in most centers, but the 1.5 T scanners are still used. What we know from work we've done and others have done, it doesn't seem to matter what this field strength is if you're just trying to make a diagnosis. So it turns out that they're both pretty sensitive and equally sensitive so that you can make a diagnosis. What we can do with the higher field scanners is we can have better resolution, and sometimes we can do a faster scan. So for individuals who I know from hearing from my patients, you have to sit in the scanner for a long time, especially if you're doing the whole shebang. A higher field strength actually gives more signal, so you can do it faster or you can get more resolution. And then finally, I will say that some of the interesting techniques that we're working on to do a better job at diagnosis and maybe prognosis are better done at the higher field strength, at 3T. And then some of your very sophisticated listeners may know that there's what we call ultra high field, and that is a 7 Tesla. And that actually is not widely available, but has been FDA approved for clinical use. And there are a handful of centers in the country that have ultra high field scanners, 7T. And with those scanners, you really can start to get very fine images of the brain. And we think this is going to be really important for research, but not necessarily for routine clinical use, because there's some complicating factors to get one of those ultra high field scanners. But what's really interesting and important, in our center now we have Pascal Satie, who is a very talented imaging scientist, has joined us. He's done a lot of research on 7T, but what he's been doing lately is taking those insights from 7T and translating them back to the 3T scanner, which can be widely used for clinical use. And so, for example, we have a project that we're doing to validate one of these diagnostic measures called the central vein sign, which we think is going to be very, very helpful in allowing us to differentiate those hard to diagnose patients who come in and have some funny little spots on their MRI, and we're not absolutely sure, is this MS or not. Having that central vein sign is a real indication that it's probably MS. And so we're going to be testing this in a big cohort it's an NIH-funded study. I think this is really going to help us to differentiate those patients and do a better job at diagnosis, which is first and foremost the most important thing. You can't be on the right medication if you don't have the right diagnosis to start.
You know, we've heard from Eileen, who said she's experienced several bouts of depression and cognitive issues since she was diagnosed with MS 6 years ago. And Eileen's wondering if it's possible for an MRI to show if there is activity occurring that's affecting the way she's thinking. And if so, how could that help inform her treatment plan?
So this is a great question, and one of those what we call hidden symptoms that people with MS have. So they're not weak or numb on one side, but they're having depression or fatigue or cognitive impairment. And there's been a lot of work that has been done to understand what's going on in patients with MS and why they're having these symptoms. And I have done in my lab work looking at a very important part of the brain called the hippocampus, which is really central for both mood and for memory and cognition. And it turns out that we and others have shown that MS affects this structure, the hippocampus, in a way that is similar to what happens when people have depression not associated with MS. And what we're finding is that depression and cognitive change is really part and parcel of the diagnosis of MS. So the first thing I would say to everyone is, if you're feeling depressed or you're having issues with your cognition, it's not because you're weak or you're not strong enough. This is a symptom of MS. And I think a lot of us now recognize this. In terms of what to do about that, it can be a sign if you're having new cognitive problems, that there is a recognition that people can have cognitive relapses. So even though you're not feeling weak or you're not having changes in your vision, for example, disease activity can be associated with these periods of not feeling well, of having difficulty concentrating, for example. And we know from MRI that there are changes in brain structures besides the hippocampus, including the surface of the brain, what we call the cortex. All of these areas are impacted by MS disease activity. So in terms of what to do, we do know that it may be a sign that your treatment is not as effective as it could be. So certainly a conversation with your neurologist about maybe changing your treatment. But we also know that there are a lot of lifestyle interventions that can be really beneficial for these symptoms related to cognitive change and depression. And those include all the wellness things I think everybody knows about in terms of getting enough sleep, exercise, eating a good healthy diet, doing mindfulness, and all of those things actually do make a difference in terms of mood and cognition, and actually decreases the inflammatory state within the brain. So we definitely recommend a holistic approach for those kinds of symptoms.
I have a feeling you've gotten this question before. Jeffrey has reached out because during the process of being diagnosed with MS, he had that initial MRI exam and he experienced claustrophobia. Now, Jeffrey's having a hard time scheduling those follow-up MRIs because of that fear. He wants to know if you have any tips to help manage anxiety during an MRI exam?
Well, this is very common. And I have to say, the first time I had an MRI done, which I do MRI research, and so very often we, test out our protocols on each other. And it's a scary process. And it does make me think that physicians who order tests should have them also so they can know what their patients are experiencing. So you're in this tunnel and it's loud and it's dark and you can't move. And so it's very frightening. So I would say first and foremost, recognizing that it's very common, and so don't feel bad about it. Secondly, there are places that do modifications to the scan process to make it a little less intimidating. Having the ability to bring your own music. Some places have ways that you can actually have goggles on and do virtual reality. That can be very helpful. We frequently will give a sedative to individuals who have this concern, so a little bit of something to relax you before you have your scan. Make sure somebody else drives you home. We've frequently found that can really make a difference. And then finally, if you really, really are having a difficult time, there are open MRIs. There are even stand-up MRIs. These are less, give us the pictures that aren't quite as clear as we would get from the traditional MRI. So we try and recommend that unless all the other things have failed. But I think just a recognition that they're not alone in this area, and there are some things that can be done to help get through that. Because at the end of the day, the MRIs are pretty important in assessing response to therapy and so forth.
Rachel wrote that she recently had an MRI and she's feeling frustrated because the results she received didn't seem very straightforward and they were in fact confusing. And she's wondering if there are questions she should ask her neurologist to help her better understand the results. So I'm wondering, Dr. Sicotte, what sorts of things do you discuss with your patients after their MRI exam?
Yeah, so this is, you spend all this time and energy to go and have the MRI scan, and then when you get the final results, you try and read it, which the radiologist report can be very confusing, or it's sort of passed over quickly. What we do in our clinic, we actually open up the scans and show them to patients. Now, some patients don't like to see them, but that's usually the minority. So we actually show the images and go over what the findings are, and we have some nice software where we can show the old scan and the new scan and show if there's been any changes, and we like to review them ourselves, as I said before. So I think what you want to do is be able to have a conversation with your neurologist or whoever ordered the scan and ask them to interpret it for you. I would also caution people, because sometimes the radiologist will do these additional evaluations where they'll be looking at individual structures and reporting out percentile rankings and things like that. A lot of those are automated tools that they're using, and they're not reliable. So I would not rely on those or get upset by what you find on those. I would definitely talk with your neurologist and have them put it in context for you, because the radiologist doesn't know anything about you, and they're just applying an algorithm to the data. So really I would say, work with your neurologist. And then if your neurologist is not able to really explain it to you in a way that makes sense to you, then you might think about moving to another person who you feel can really work with you, because at the end of the day, you have to feel confidence in the data that's being generated and how it's being interpreted for you.
Dr. Sicotte, we should mention that you're the founding member of the North American Imaging in MS Cooperative. Could you tell us about the work of the cooperative, and is there anything you can share with us about the future of imaging and MS?
Well, thank you for mentioning that, John. It's a wonderful group of great collaborators. Really, this is the brainchild of Danny Reich. Dr. Reich is a very well-known imaging expert who's at the NIH. And it was really his brainchild, along with the Centers Without Walls, which is part of the Race to Erase MS group. And that's where the nidus of the name started. But now we've grown to over 30 centers in North America, so in Canada and in the US. And really what we're working to do together is to really advance the field of imaging. And we are looking at the cutting edge techniques that will be in the clinic in the future. So we're developing those techniques for the future. And our signature project so far has been the central vein sign. And now we're moving to another kind of imaging approach, which is looking for these, what we call paramagnetic rims. These are another kind of change within the brain that we think might be important for this prognostication, as I told you about. So it's a wonderful group, very collaborative. We come together once a year and review important areas within imaging and MS with the goal of, again, setting kind of the research agenda to really keep driving things forward so we can learn more about MS, we can help our patients, and ultimately tackle some of the really tough questions like, what are the underpinnings for progressive MS? And how can we do a better job of using MRI to measure effects of treatment on not just those white matter lesions that we've been focusing on, but some of these other changes, like we know there are lesions on the surface of the brain, in the cortex. And we don't know really if our therapies are impacting those lesions as much as they are the white matter lesions. And so we really need better tools to address those questions. So I'm very proud and excited to be a part of this group and this new multi-center trial that we have on the central vein. It's called CAVS MS. It's 11 centers throughout the country. The organizing center is at the Cleveland Clinic with Dan Antoneda and myself as the other co-PI here at Cedars. And so it's all across the country. So there may be opportunities for individuals who are on the call to be involved in that project. And certainly we hope the field will benefit from it. So thank you for mentioning that.
And thank you for helping us better understand the role and the importance of that MRI exam in diagnosing MS and following future disease activity. Before we continue our conversation, I want to welcome those of you who have continued to join us on GoToWebinar, Facebook Live, and YouTube Live. Please let us know what's on your mind. Post your comments and questions on Facebook and YouTube, or type them into the question box if you joined us on GoToWebinar. With the exception of our upcoming holiday break, our Ask an MS Expert live event takes place at this same time every Friday. So please help us make sure that everyone knows about it by sharing news about the webcast with your family and friends. And we're planning to resume our regular schedule and be back with you on Friday, January the 8th. We're talking with Dr. Nancy Sicotte, professor and chair of the Department of Neurology at Cedars-Sinai Medical Center in Los Angeles. And we've been discussing the importance of MRIs in the diagnosis and management of MS. But what's clearly been on the minds of, well, most everyone is the recent approval of a COVID-19 vaccine and the pending, any moment now, approval of a second vaccine. So I'd like to shift gears and focus on what we know so far. The National MS Society has convened a group of experts to provide guidance for people living with MS when it comes to making decisions about the safety, efficacy, and the timing of COVID-19 vaccines as they relate to certain MS disease-modifying therapies. Dr. Sicotte, as the chair of the Society's National Medical Advisory Committee, is leading this effort. So, Dr. Sicotte, the approval of a COVID-19 vaccine has created just a tremendous amount of hope that we may be moving to a new chapter in fighting the virus, but I know there are many questions that still need to be answered. Can you tell us what some of the key questions are that your task force is working to answer?
Thank you, John. So as I've said a few times this week, it's the best of times and the worst of times here, especially in Los Angeles, where we're experiencing the most severe surge of this entire pandemic. And at the same time, the first shipments of the vaccine arrived and our frontline workers are starting to be vaccinated. So we're dealing with both of these things simultaneously. And I have to say that it's just an unprecedented time for all of us. So I'm very grateful that in my role as the chair of the National Medical Advisory Committee, the first item on the table when we talked about our goals for the year was to convene this task force. And as you've alluded to, this is a very rapidly evolving situation, but we're very lucky to have experts who have joined us from the NIH, who are virologists. We have experts also on immune responses, and in particular after vaccines. We have clinicians, and we also have representatives from the Canadian MS Society. We have Brenda Banwell, who also is the chair of the MS International Federation. We have representation from the Consortium of MS Centers. And so this allowed with Scott Newsom. And so this allows us actually to create advice that is consistent across all of these groups. And I think this is the most important thing for people who are living with MS, is the information that they receive needs to be consistent, because we're starting from a point where there's a lot of confusion and a lot of mistrust, I think, about the whole vaccination process and how it's been developed. So first, I want to start by saying, as you said, we have approval, but we have an emergency use authorization. So the FDA has actually not approved the vaccine in the way they would for general use. It's only as an emergency use. So individuals who receive the vaccine actually sign a consent form saying that they're getting this under this auspices. This allows the vaccine to get out there and be out and used. So the first thing I would say, based on everything that we've looked at, and we've been looking at all the data, we have all the data from the studies that were done. The FDA has shared this widely, and anyone who's interested can go to the FDA website and download the long and complicated data that's there. But it's also been published, the first vaccine, which is from Pfizer, that data has been published in the New England Journal of Medicine. So it's a very transparent process, and I just want to assure everyone they are following the usual routine scientific method to evaluate the safety and efficacy of the vaccines. So I'd say the good news is for the first two, which are very similar in the way they work, these two vaccines we have seen to be very safe and incredibly effective. They have a 95% vaccine effectiveness. So this I think is the most important thing as we think about why the vaccine is important and the advice we would give to our patients. We are in the middle of a pandemic. The virus can be deadly. And in particular, it can be deadly to people living with MS who have other comorbidities. The only way we will get out of the pandemic and provide a safety for vulnerable people is for lots and lots of people to be vaccinated. Otherwise, the virus will continue to be out there. We see how widespread it is. And so it really is important that we get behind the vaccine and think about this as a way to get back to a safer world for all of us. Now, that said, I know that people have concerns about the vaccine because first, the speed at which it was approved and because of the novel way the vaccine works. And then finally, it hasn't really been tested specifically in MS patients. So within our group, we've been talking about all of these things. And the good news is the vaccine technology is such that it doesn't raise concerns for people who have autoimmune diseases in any particular way. So we think it's going to be a safe vaccine for MS patients. The truth is, right now, patients are not able to get access to the vaccine because it's limited to frontline workers, and nursing home patients will be the next. Now, there are some people within those groups who have MS. I have several patients who are healthcare providers who also happen to have MS. And it's an interesting conversation about risk and benefit. And so what we've seen so far, I just would say the top line is we're seeing very few risks with the two mRNA vaccines, and we obviously see a great benefit. So I think for patients who are feeling anxious, that we will have more data by the time it's available for the general MS population. We will have at least several months of many, many people across the world who have received the vaccination. And so we'll have an even more robust set of safety data to help guide us. So I know there are a lot of questions that we can go through, and I just want to give that sort of top line.
I think that's very, very helpful already. I'm curious, when do you anticipate your task force will issue its guidance?
So right now, we've had 2 very fruitful meetings. We have another one scheduled next week, and we're hoping to have our initial guidance posted on the website, the National MS Society website, by early January, so just after the first of the year. And the other thing I want to emphasize is this will be a living document. So this will be something that will be updated regularly. As you alluded to, now the Moderna vaccine will likely be granted emergency use authorization, and we know the AstraZeneca vaccine is in the pipeline. And so we may well have very different advice for these individually different vaccines, because they're all slightly different in terms of their handling and in particular how they work. So I would encourage everyone, first and foremost, we all need to take a deep breath and recognize that this is going to be a months-long process, and that we will be getting more information over time, and we will always be constantly updating the advice that we give based on that information that we're going to be gathering, which I think will give people a lot of confidence moving forward with the vaccine.
I think that's a really important point to make. I know that some of the things we've heard about some of the precautions to take during the pandemic, people have said, well, they didn't say that at the beginning, but the truth is so much of this learning is taking place in real time.
Yeah, I think this is one of the challenges, and I think it can be a source of misinformation. And it's a little bit of a misunderstanding about the way that science works. We are constantly looking for information that will help us better understand whatever the process is that we're dealing with. And sometimes we don't have all the information to start. And so we have to keep recognizing that we'll learn things. Like, remember masks at the beginning, they said, oh no, you don't need to use a mask, nobody should use a mask. And now we realize that a mask, truthfully, is almost as effective as the vaccine in terms of preventing new infections. But you have to be able to say, now we know, and now we're going to change our advice based on that. So I think that people should recognize that by the time that they're going to be offered the opportunity to have a vaccine, we will have more information to guide decision making. But I do want to go back and just talk a little bit about what we do know about vaccines in people who have MS already, and which is quite a bit. And in fact, we know that from studies done with the flu vaccine, that vaccination in general in people who have MS is safe and effective. And the only caveats are live vaccines that we have advised our patients to avoid. But none of the vaccines that are being offered for the coronavirus that are live. There's no live vaccines being developed or offered for COVID. So I think all of our patients should feel confident in that. And what we should also recognize is what we've learned from the flu vaccine is those individuals who get the flu, who haven't had their flu vaccine, they get the flu, they are much more likely to have a relapse than people who got the flu vaccine. The flu vaccine will protect you from the viral infection that we do know viral infections can frequently trigger relapses. So prevention is better. And I think that in terms of the pandemic, it's even more of an important conversation because the virus is so ubiquitous and can be deadly. And so when we think about the risk and the benefit, we have to take those factors into consideration.
I think I heard you say a moment ago that by the time this vaccine is available for some of the people who are watching us today, and that actually brings us to a question from Steve, who is asking who is being prioritized and how. And then we have a similar question from Christina, who wants to know if people with MS will be classified as high risk and would be prioritized higher to get the vaccine. So what can you tell us about prioritizing access to the vaccine?
Yeah, this is a hot topic and a hot question, and I think really important that we're very clear about this. So the first prioritization are healthcare providers. And that includes not just physicians, but nurses and individuals who are on the front lines, people in the emergency room, first responders who are out in the community and who are regularly exposed to individuals who may have COVID. And so I think that there's been some discussion about, is that the right way to do things? But I think if you think about it, it's like on the airplane where you put your oxygen mask on first so you can help others. So if the helpers don't have the oxygen, then they can't actually help people who then develop needs. So I think it does make sense. And we've seen our ICU and other first line folks be exposed on a regular basis with lots and lots of people with COVID. So this allows us to have the care available. Second would be the very most vulnerable population, and that's people who are in nursing homes or group living who are elderly. And I think that all of us have seen the devastation that has happened in these group home living situations where the mortality rate is extremely high. And so that's the next priority, is to get the most vulnerable group living elderly individuals. After that, there is a hierarchy that has to do with risk and comorbidities. And MS patients are definitely within that category in terms of having a higher risk than the general population. At the very bottom of the list will be the people who are young, otherwise healthy, have no comorbidities. So they'll be the last to receive it. So I also think we should be thinking about how this will flow. And it's a little bit like this positive wave that will happen, because as more and more people get vaccinated, fewer and fewer people will get infected. There'll be less and less transmission in the community, and it will be this sort of positive feedback loop that will give us a lot of hope. And I think will also give people confidence and accelerate the use of the vaccine.
Robert is asking, what are the side effects that people should expect?
Yeah, so great question. So what we know is what I can talk about are the side effects from the two, what we call mRNA vaccines. So these are the two, the Moderna, which we think will be approved today, and the Pfizer, which is already approved. So both of these involve two vaccines, so two shots. So you get one shot, and then if you're doing the Pfizer, 3 weeks later, you get a booster. If you're doing Moderna, there's 4 weeks in between. So what we know is that typical kinds of things, like, when you get the flu shot, you get a little bit of a muscle ache. Sometimes, you want to do it in your non-dominant arm. So a little bit of that. Very, very rarely there have been people reported who have a hyper allergic reaction to the vaccine. And these are people who typically are carry around an EpiPen because they have this kind of reaction. So that's extremely rare. Then the second shot is when individuals are more likely to have a few more symptoms, and those include things like chills and maybe some muscle aches, some fatigue, maybe a headache. And from everything that we've read and seen, that is very limited. It's about 24 hours of a little chills or not feeling well. Because of that, actually, we've been staggering our cohorts, so we don't have all the ICU nurses get their vaccine on the same day, just in case they come in on the second shot and have a little bit of these kind of side effects. But in general, that they've been very mild and self-limited, so that's been very encouraging.
Jessica is asking whether once someone gets the vaccine, can they still spread the virus?
So this is a great question, and this is an unanswered question because we don't know. So the way that the vaccine works, at least these two that are coming out, they block this spike protein and keep that spike protein from getting into your cells. So in order for the virus to live, it has to get into one of our cells, hijack the machinery there, and make more copies of itself. So if it can't make copies of itself, the virus doesn't live that long. But the question is, if you had the vaccine, could you harbor some of the virus that doesn't hurt you and then spread it to other people? It's not known. And because of that, even for people who've been vaccinated, even for people who've already had COVID, who we assume have some immunity, the recommendation is to continue wearing your masks. So invest in your mask, get a cool looking mask. We're all going to be wearing them, I think, for several months to come. But that's a very great question, and there is work being done to really answer that question because it's very important.
Phyllis wants to know if there's information about how long the vaccine will last once you get that second shot. Will it be an annual vaccine like the flu shot?
Another very great, sophisticated question, and the short answer is we don't know. But the longer answer is, if you look at the robustness of the immune response and what we know about other kinds of vaccines, we think that this will give long-lasting immune response and protection. And that's a really good thing because we don't, the less we have to worry about this in the future, the better. Now, that remains to be proven. But from all of the experts that we've brought onto the panel and the work that we've done, based on the responses we've seen, we think it's going to give us long-lasting protection. Maybe there would be a booster at some point, but I don't think it will be the same as the flu, because the flu there are lots of different varieties of the flu. And so far, at least for COVID, there have been small changes that have occurred, small mutations, but they're not related to the spike protein. So the spike protein is the same across the different versions. And so the vaccine should work on all those minor variations that have emerged during the pandemic.
Heather wants to know more about how these vaccines have to be stored. She says that it sounds like it's going to be a challenge to store them.
Yeah, that's a great question. And that's why the Pfizer vaccine is the most difficult, because that has to be stored at ultra low temperature, so minus 70 degrees. And those kinds of refrigeration units are not available at the local CVS or drive-through where you might get your flu vaccine. So the truth is the Pfizer vaccines have really been targeted to places like medical centers that have a lot of these refrigeration units and are able to accommodate them. And that has to do with the way that the vaccine was made. There are these little nanoparticles that are made of lipids, and in order for those to stay stable, they need to stay very, very cold. The Moderna vaccine also needs to stay cold, but not ultra cold. So that will have a benefit that it could go potentially into standard refrigeration. And so that will have an even wider use. And then finally, the AstraZeneca, I don't think doesn't have a lot of really special handling requirements. Again, we'll have to see when the final data comes out. So that might be one that's very widely available. And so it is interesting how they're rolling out now. With each successive opportunity, it looks as though we'll be able to spread it out wider and have more access for people.
Well, we've received a few questions that all seem to be asking the same question. And that is, what should people living with MS do now while this guidance around the vaccines and their impact on MS is being worked on?
Yeah, so great question. I think so I would just say sit tight and start conversations, well, I would say get information. So inform yourself about what the vaccines are and their relative safety and efficacy. And I think you will feel much more reassured. I know I have been very reassured by looking at the data, seeing the quality of the information, and feeling very confident that they have evaluated these in the proper way. The second thing, and this is a nuanced conversation, and it has to do with the medications that we're using to treat MS. And this will be part of our guidance, and we've just started talking about this, and that is, what is the role of the disease-modifying therapies in the vaccine response? And the short answer is most of the drugs we use don't have any impact. And so you should continue to use your medications the way they've been prescribed. And that is the injectable therapies, most of the oral therapies, and natalizumab, for example, fingolimod, we don't think that those medications are going to impact the response to the vaccine. The only caveat is what we call the B cell depleters and some of the other highly effective medications. They may cause you to not respond as robustly to the vaccine as you would otherwise. So we do have some information on like ocrelizumab and rituximab after vaccination. Because of the way those medications work, the cells that would normally respond to the vaccine have been decreased because of the effect of the medication. And so when we look at immune responses to the vaccine, they're a little bit less than what you would see if you weren't on that medication. So it comes to a question of timing of when you would want to get the vaccine versus get your infusion if you're doing, say, 6 monthly infusions. So that's a little bit of a tricky question. We think, just to bottom line it, we would not recommend getting your treatment, your infusion, your Ocrevus or your Rituxan, and then immediately getting the vaccine. You're likely in that scenario to not have as good a response. The best case would be you're just about to get your new infusion, and you wait and do your vaccine at that very end point, and then do your infusion. So that's a little bit of the nuance that we're working through, and we're going to have very specific advice for practitioners as well as for patients. So I don't want to sow confusion, but there is a subtlety there related to what we call B cell depleters.
Well, we've covered a lot of ground, from the role of magnetic resonance imaging in MS to a very timely conversation about the COVID-19 vaccines and their potential effect on people living with MS. And I'm hoping that you'll share the top 3 takeaways that you'd like our audience to keep in mind.
Okay. So first, if we talk about MRI, that your MRI scan is very helpful as an ancillary to your exam and your history. And this really powerful for not only diagnosis, but for management. And stay tuned, because we'll have some new techniques that are going to be even better in allowing for more personalized medicine. The other two takeaways I would say have to do with the vaccine. And that the first takeaway is there's a lot of fear about vaccines, but in truth, vaccines are safe in general for people who have MS. And they're beneficial. And so we want to be thinking about vaccines in terms of the risk and the benefit. The risks are very low and the benefits can be quite high. And then number 3, I would say that the pandemic is going to come to an end. And the best way to make that happen quicker is if most people will go ahead and get vaccinated and allow us to eliminate the transmission of the virus throughout our community. And ultimately, that is what's best, not only for our patients, but for all vulnerable people across the world.
Well, I want to thank you, Dr. Sicotte, for sharing your expertise with us today. Thanks to all of you who've submitted some really great questions. And again, thanks, Dr. Sicotte. It was great having you with us today.
Thank you, John. My pleasure. And I hope that I'll come back again after the first of the year and give another update, or allow you to advertise our updates to keep everyone informed, because that's our goal.
We'll definitely hold you to that and look forward to it.
Great. Thank you.
I think that one of the best things that anyone can do for themselves, especially during these uncertain times, is to make sure that the information they're getting is credible and reliable. So we'd like to share some resources with you, and these are resources that you can count on. I want to remind you that if we were unable to get to your questions today, the National MS Society's MS Navigator team is your best partner in answering those questions and connecting you to the very best information and resources. For more information and resources on MRI or COVID-19, please go to the MS Society's website at nationalmssociety.org, and you can search on the terms MRI or COVID-19. These are especially difficult times for so many people, And I want to make sure that you're aware that the National Suicide Prevention Lifeline is available 24 hours a day, 7 days a week. They offer free and confidential support for people in distress, as well as suicide prevention and crisis resources for you or your loved ones. You can reach them by calling 1-800-273-TALK. That's 1-800-273-8255. Every week on the Real Talk MS podcast, I continue the conversation that we start here. So I hope you'll take a few minutes and give Real Talk MS a listen. You'll find the Real Talk MS podcast at realtalkms.com, Apple Podcasts, Google Podcasts, Spotify, Amazon Music, wherever you find your favorite podcasts. With vital funding from supporters like you, the National MS Society will work to ensure that resources and programs like today's are available, and that the MS research community rebounds quickly from COVID-19, so the progress and momentum toward finding a cure continues. As you're able, please make a donation to the Society's COVID-19 Response Fund by texting the word GIVE to 68686, and you'll get a link right back to this MS Society's COVID-19 Response Fund webpage. I hope you'll consider contributing today. You can connect with the National MS Society on Facebook, Instagram, Twitter, YouTube, and LinkedIn. And please make sure that you're on the Society's mailing list so you'll continue to receive the latest information on MS research and updates on upcoming programs like this one. I'd like to thank Dr. Nancy Sicotte for joining us today, and I'd like to thank everyone who's joined us for your great questions. Please remember that a recording of this webinar is going to be available for your review on the Society's website at nationalmssociety.org/MS-expert. And just a quick reminder again, we're taking a brief break for the holidays. I hope you'll be joining us when we resume our regular schedule on Friday, January 8th. And now I have a favor to ask each of you. Getting your feedback on today's webinar is important, so you'll see a survey pop up in a moment when we close out. And if you're watching on Facebook Live, you'll see a link to that survey pinned to the comments section. And on YouTube, you'll find that link in the program description. Completing the survey makes a real difference. The information you provide helps us continuously improve, and it helps shape future programs. The survey takes just 1 minute, so I hope you'll take a minute and please fill it out. On behalf of Dr. Nancy Sicotte and the National MS Society, I want to thank you once again for joining us. Please stay safe and make healthy choices.